እሺ ሁላችሁም እንኳን ደህና መጣችሁ የተገኛችሁት ያው ጥሪያችንን አክብራችሁ እዚህ ስለተገኛችሁ በጣም አመሰግናለሁ። ዶክተር ዮሴፍንም ይሄንን ዝግጅት ለማቅረብ ፈቃደኛ ሆኖ ዛሬ በመገኘቱ በጣም እሱንም አመሰግናለሁ። ይሄን ካልኩ በኋላ ዶክተር ዮሴፍ ሌክቸሩን ከመጀመሩ በፊት የተወሰነ አናውንስመንት በቅርቡ ከአብረን ከምንሰራቸው የኢትዮጵያ ሜዲካል ስኩልስ ጅማን ጨምሮ ጎንደር፣ አርባ ምንጭ፣ አርማያ የአሜሪካን ሀገር የሚዘጋጀው የአፕ ቱ ዴት የኦንላይን ሜዲሲን ሪፈረንስ ተጠቃሚ መሆን ችለዋል። በአሁኑ ሰዓት ባለኝ መረጃ መሰረት በፍሪ ሰብስክሪፕሽን አግኝተዋል እነዚህ ሜዲካል ስኩሎች እና አፊሊየትድ የሆኑት ሄልዝ ሴንተሮች ማለት ነው። እና ከትላንት ጀምሮ ይመስለኛል እዛ ያለ ያው ማንም ሰው አክሰስ ማድረግ የሚችልበት አፕ ቱ ዴትን ሁኔታ ተፈጥሯል ማለት ነው። ይሄንን ያው ፋሲሊቴት በማድረግ የኛ ድርጅት ኢዲፓግ ሚና ተጫውቷል። በእርግጥ ኮስቱን ዶኔሽኑን የሰጠው የኛ ድርጅት አይደለም፣ ግን ያንን ያደረገውን አሜሪካ ያለውን ቤተር ኤቪደንስ ፎር ትሬኒንግ የሚለውን ድርጅት ከሜዲካል ስኩሎቹ ጋር አገናኝቷልና እጅግ በጣም ደስ እንዳለኝ ነግራችሁ እወዳለሁ። በዚህ አጋጣሚ ይሄ ትልቅ አስተዋጽኦ ነው። የተማሪዎችን ኢቭን የአቴንዳንቶችን የኤኒ ፐርሰን እውቀትን ለማጎልበት ማለት ነው። ከሱ ውጭ እንግዲህ ኤድፓግን ለማታውቁ አዲስ ለሆናችሁ ኤድፓግ ኢትዮጵያን ዳያስፖራ ፊዚሽንስ አሶሲዬሽን ማለት ነው ከተቋቋመ 1 ዓመት ይሆነዋል። ዋና ዓላማው ኢትዮጵያ ውስጥ የሜዲካል ቲቺንግ እና ሜዲካል ሰርቪስ ኳሊቲን በመጨመር ለማገዝ ነው እና በተቻለን መጠን ከተወሰኑ ሜዲካል ስኩሎች ጋር በጥምረት እንሰራለን ከኢትዮጵያ ጤና ጥበቃ ሚኒስቴር እና ሪጂናል ሄልዝ ኦፊስ ጋር እንደ አስፈላጊነቱ we work together። ይህን ካልኩ በኋላ የዛሬውን አቅራቢያችንን ዶክተር ዮሴፍ ብርቁን በጥቂቱ ላስተዋወቃችሁ። እሱ ባለኝ መሰረት ዶክተር ዮሴፍ ኢትዮጵያዊ ነው። አዲስ አበባ ነው ተወልዶ ያደገው። እዛ በሚገኘው አዲስ ከተማ ድሮ ልዑል መኮንን የሚባለው ሃይ ስኩል ነው ተምሮ የጨረሰው። ከዛ በኋላ ሕክምና ያጠናው ጎንደር ነው እና በ1990 ያው በፈረንጆቹ ይመስለኛል ግራጁዌት አድርጓል አይደል ዶክተር ዮሴፍ?
ልክ ነው
በፈረንጆች 1990 ኦኬ። በእኛም ፕሮባብሊ 1982 83 ይሆናል።
ኤግዛክትሊ
ከግራጁዌት ካረገ በኋላ ያ እኔ ወደ ጅማ ስሄድ ማለት ነው አንተ የተመረቀው after 4 years of work as general practitioner Ethiopia ውስጥ he did his master of science in clinical pharmacology አዲስ አበባ ዩኒቨርሲቲ ነው ይሄን ያደረገው። ከካሮሊንስካ ዩኒቨርሲቲ ኦፍ ስዊድን ጋር በመተባበር ማለት ነው። he was a member of Black Lion faculty of medicine for 2 years. Then he moved to Botswana as a senior medical officer and then to ultimately to United States and further studied internal medicine and infectious disease. ከ2010 በአውሮፓውያን አቆጣጠር ጀምሮ he is practicing infectious disease at various he has been practicing at various regions of United States. He is board certified in both internal medicine and infectious disease. እና በአሁኑ ሰዓት he is a consultant infectious disease specialist at Centara Medical Group in Norfolk, Virginia. He is also a member of several medical societies including American College of Physicians, Infectious Disease Society of America and American Medical Association. Without further ado, I would like to give the stage to Dr. Yoseph. Thank you.
Thank you, Dr. Samson. We may mix some Amharic, but generally the presentation would be like any scientific presentation in English. Obviously, thank you for your kind words and introduction. And my talk would be very limited and overview. But from the outset, I want to do some disclaimer, which means I don't have any conflict of interest and I'm not affiliated with any of the pharmaceutical product. If I mention some brand names, I'm not advertising any particular products. The objective of this presentation would be generally to see overview of the magnitude of the problem of hepatitis B and C and how we approach diagnostically and the therapeutic approach and some of the preventive strategies. This slide tells you, because hepatitis C, by the way, is one of the areas over the last 10-15 years has transformed so much, and it became very easy to treat nowadays because of this advance. And it is an RNA virus, and we call it positive strand RNA because it serves as messenger RNA itself, so it doesn't need a lot of assistance to reproduce. It has a lot of varieties of genotypes, so far well known up to 7, but the 8 and 9 has been discovered as well. This has been very important in terms of picking medications, targeting medication, but nowadays we'll also talk about it. We have what you call pangenotypic medications, which can target all the genotypes. Structurally, this is mentioned because this diagram shows an area where you can see what kind of target you have. Majority of medications are targeting non-structural proteins of the HCV virus, particularly the protease inhibitors or the directly acting antivirals affect the N3-5 and N3-4 targets are mentioned later, but this is more important for people who deal, resistance studies and so on. Overall, it is one of the common infection in the world. More than 71 million is estimated to be affected, but in sub-Saharan Africa, it varies from region to region. It's about 2.9 to 3%, at least based on the study in 2016, and based on some observation and report by Ethiopian writers, in 2017, the estimated prevalence in Ethiopia was 0.7%. And the transmission of this virus varies from areas to the areas. In the Western world, it's primarily affecting people with intravenous drug users, men who have sex with men, and because of the percutaneous exposure of blood. In developing countries in Africa, the majority of transmission is due to unsafe medical practices and also very risky transfusion if not screened well. One question we always get is the chance of transmission of hepatitis C through sexual transmission. Apparently, this is very infrequent, except in selected population, particularly in MSM, because this needs a certain environment to be transmitted. So in discordant heterosexual couples, if the husband is hepatitis C positive and the wife is negative, the chance of transmission is very insignificant. That has been seen repeatedly in our clinical practice. A clinical manifestation, majority of hepatitis C infections are asymptomatic, which means you don't see much of clinical pictures in patients. It's very unusual to have an acute illness like fulminant hepatitis with right upper quadrant pain, malaise, jaundice, and this is extremely rare. But the main transition would be to a chronic stage, which is 75% of infected people will go to chronic infection, and which leads to eventually to cirrhosis, hepatic steatosis, and hepatocellular carcinoma. And this slide overall may not apply in Ethiopian setting. Who should you screen for hepatitis C? If, of course, in the Western setting, historical precedence tells us that people who are born in 1945, between 1945 and 1965 has to be screened. But generally now, the new recommendation is almost anyone, adults, has to be screened for hepatitis C because it has been very cost effective to screen and treat. And some of the other high-risk groups include IV drug users, people who had transfusion before 1987 or 1992 when they received blood organs. But in the setting, in Ethiopian setting, I think the main area we have to focus is healthcare workers and people on hemodialysis, and people with evidence of liver disease. All this has to be screened. And in children born from hepatitis C positive women has to be screened. So particularly healthcare workers, surgeons who are encouraged to get screened. This is the overall diagnostic approach. So it's very simple. You suspect hepatitis C, you just do hepatitis C antibody serology. If that is negative or non-reactive, then possibly the patient has no infection, more than 99%. But if that person is a high-risk group, you can still keep following him in 3 months, 6 months to make sure that he remains negative. But if that hepatitis C antibody is positive, then you have to do what they call hepatitis C RNA level, which means you have to determine the amount of virus. And that can be done quantitatively, or sometimes, depending on the setting, they do what they call qualitative HCV RNA or PCR test. If that is not detected, obviously you don't have, or that person may don't have current infection, and additional testing depends on the risk of the person. And you may continue to follow his risk factor accordingly. But if that is positive, then it has chronic hepatitis C infection, and then you have to link to care, and that depends on the underlying circumstance where you practice. Of course, in majority of cases in US, the management of hepatitis C is by infectious disease or GI, but that doesn't mean this is a complicated thing, and it can be managed in a primary care health setting. What is the overall progress of hepatitis C if untreated? Majority of patients, 75% to what you call, they go to chronic infection, and 25% go to spontaneous resolution. And among 75% with chronic infection over 20 years, up to 20% of them go to cirrhosis, and the remaining may not go into cirrhosis. And among patients with cirrhosis, 1 to 4% per year will go to liver failure or hepatocellular carcinoma. One thing you have to mind is here, in hepatitis C, it's almost always the case that hepatocellular carcinoma comes after the patient develops cirrhosis, unlike hepatitis B, which can go from chronic infection directly to hepatocellular carcinoma without cirrhosis. Again, this is when to pick the hepatitis C antibody in acute infection. Usually 4 to 10 weeks, you can detect the antibody, but more than 97% by 6 months, they have a positive antibody. And one thing we have to remain clear is even people who cleared the infection, they will remain to have hepatitis C antibody. So people who have antibody for hepatitis C virus, who has cleared the infection, they are not immune because they can get infection again, but at least it can tell you that they had prior infection. What about the PCR, the RNA? That one, you can pick it within 2 to 3 weeks after infection. And once you confirm infection and you have confirmed that patient has chronic infection, you don't need to follow the hepatitis C virus level to determine progression of disease, because it doesn't tell you much unless that person is going to be treated. And genotype of hepatitis C virus, it used to be very crucial. Still we do it, but nowadays with availability of pan-genotypic treatment, we don't need necessarily to do that. By the way, the common genotype in Ethiopia is genotype 4. And in terms of management, of course, every hepatitis C patient has to be, looked up for possibility of stage of the chronic liver disease, depending on how much fibrosis they have. And the other thing is you have to check hepatitis B and HIV. These are the common co-infections that you may find. So those people has to be also advised to avoid hepatotoxic medications. They have to be vaccinated for hepatitis A and B if they are not already infected. And they have to be advised to avoid alcohol consumption altogether. And of course, they are at risk to transmit the disease. So they don't need to donate body fluids, and they don't need to share, razors, clippers, anything, toothbrush, which can potentially transmit infection. The treatment outline is very, it's very intense treatment protocols. In a sense, there is a lot of advance, a lot of choice to treat, but the resource availability determines which medication to use. In general, the primary aim of treating is to eradicate hepatitis C, which is curable. That's why it's considered as a preventive mechanism. Once you treat a patient, you avoid transmission. According to the American Association of Study of Liver Disease and Infectious Disease Society of America, there is a regularly updated treatment recommendation on hepatitis C, which you find at hcvguidelines.org, which is open to everybody, free, updated information, which is basically every couple of months, new information is available. And that includes even in those patients with co-infected with HIV and other high-risk groups. The older regimens, including interferon-based treatments, are no more used. And like I say, directly acting antiretroviral, directly acting antivirals are preferred. And the general duration is 6 to 12 weeks, depending on the degree of fibrosis, depending on the genotype, and depending on the level of prior exposure to treatment. Once people are on treatment, certain things that we need to monitor is particularly the hepatitis C virus viral load at 4 to 12 weeks, and then 12 weeks after completing of treatment, which is called SVR, to document sustained viral response. And there are other areas that I mentioned that we need to follow if patient has fibrosis or not, because even if you completely treat hepatitis C, you have to make sure that that person will not develop hepatocellular carcinoma if they have fibrosis or cirrhosis. So there are several ways to assess that, but one thing which is practiced now is liver biopsy is rarely used nowadays. We use here a couple of things in terms of imaging, liver transient elastography, what you call fibroscan, which measures stiffness of the liver, and there are degrees of measurement, but this is not universally available. But there are a couple of blood work that you use very easy. Anybody can use it, and I will share the formula, but you can plug the numbers and calculate the what you call APRI score, or which is AST to platelet ratio index, and the other one is FIB4 or fibrosis 4 calculator, which determines how far you are in terms of the that person's fibrosis. And these are simply anybody with a mobile phone can calculate once you know the AST level of that person and the platelet count. So this in general tells you the lower platelet you have, the higher the APRI score, or the higher AST you have, again, it tells you the degree of fibrosis. And again, this FIB4 also tells you the degree of fibrosis. Once you determine that patient has fibrosis or cirrhosis level, then you have to follow that person every 6 months with ultrasound to make sure he doesn't develop hepatocellular carcinoma. And the other overview is what is the treatment approach in the past and in present. Of course, like I said, in the past, we had interferon-based therapy, which is terrible in terms of side effect, and they don't have the success that we want to achieve in those days. But at present, with more than 95% success, we use directly acting antivirals and very short duration of treatment and with success. But this treatment, like I said, is evolving with newer medication, making it important to say that to stay up to date with the latest guidelines, which you'll find in this hcvguidelines.org, which is free, like I said. And this is also, it looks a complicated slide, but it just tells you how many class of medications we have and how to use it. You don't need to memorize this, obviously, because this is something it's important for people who practice every day. Otherwise, majority of this medication also may not be available. But what I learned, at least you can correct me if I'm wrong, is there is only Harvoni, or a combination of Lidispir and Sofosbuvir, which is available in Ethiopia through Gilead. And I'm not even sure how widespread the availability. And the other, in general, we use a combination of either NF3 with NF5 inhibitors or a combination of NS5 inhibitor with polymerase inhibitors or NS5 bRNA polymerase inhibitor. So a lot of options, but we have to have some kind of national guideline to use. Otherwise, the choices are so vast. How about prevention? Prevention in general in hepatitis C is, of course, avoid exposure to needles, but screening of all products, blood products in healthcare setting, and reduction of intravenous users in a setting where there is one, and high coverage screening and approach with high risk population, and then treat them. And this is called treatment as prevention. This could be successful because the WHO is targeting by 2030 at least to diagnose 90% and treat 80% of those eligible people. So it is doable, but it needs a lot of commitment. Vaccine generally is not a feasibility in this case because of extensive viral diversity, and at the same time, if the eradication is possible with medication, it is worth spending your resource in that area. But the major barriers to elimination is, one, it's suboptimal diagnosis because of availability of resource, poor access to directly acting antiviral therapy, and of course, lack of government support or coordinated efforts. Shifting gears into hepatitis B, probably this is more common than hepatitis C, but the advantage of hepatitis B is there is a vaccine, and majority of places where they are close to do universal vaccination of kids, children, and then that's potentially elimination of hepatitis B. So it's a chronic progressive disease, hepatitis B. It's nearly 5% of world populations has chronic hepatitis B. In the Ethiopian setting, there is a report of pooled prevalence of 6%. This is based on blood screening that has been done. And you can see this as this slide. Majority of the hepatitis C in Africa, particularly in the Western area, is more than 8%, which should alarm us to do more. But in areas like in Taiwan, they did a lot of intervention through vaccination and improved socioeconomic status and effective treatment. They were able to reduce the prevalence. But on the other hand, in other Western areas, due to migration, the number continued to rise. So this is a DNA virus, as you know, and unlike hepatitis C, this can't integrate into human genome. So that's why it's a chronic infection. It cannot be eradicated. Once a patient is infected, potentially he has a chance to relapse at one point in his lifetime. But replication is using reverse transcriptase using RNA intermediate. The acute infections varies from asymptomatic to fulminant, and usually incubation is about 1 to 4 months. But it's very difficult to distinguish from other flu-like symptoms or other viral or acute hepatitis unless you do the study or the test, and unless you have clear-cut exposure history. And very rarely in children to see symptoms, especially under 1 year, but almost 10% of children younger than 5 years may have symptoms, but the older the person, they have a higher chance of symptoms. About 2/3 of cases are either subclinical or only diagnosed in retrospective history. Risk of chronic transition to chronic infection is actually inversely proportional to the age of accusation of infection. So in kids, that's why in developing world, kids, when they get infection in utero or from their mothers, then they have a high chance of getting chronicity up to 70 to 90%. And as you get older, the chance of chronic infection is 5 to 10%. And other high-risk groups like, IV drug users, HIV patients, MSM, or what you call men who have sex with men, have high risk of chronic infection. This slide is, of course, I'm sure you are aware of, how to distinguish or interpret a serology result of a person with acute hepatitis B or versus chronic or versus someone with immunity to infection through infection or immunity through vaccination. As you can see, if someone is having acute hepatitis B, the marker that you have to see is hepatitis B E antigen, anti-core hepatitis B C, or IgM for anti-hepatitis B core antigen, and hepatitis B DNA and ALT or serum aminotransferase may rise. Immunity through infection, you can pick it by antibody for anti-hepatitis B surface antigen and finding of anti-hepatitis B or envelope or anti-hepatitis B core antibody. So this chart is almost always universally used anywhere, and you can see chronic hepatitis C has all the pictures except anti-hepatitis B surface antibody. And the progress of chronic hepatitis B, like I said, it varies from age-wise. The earlier the infection happens, the higher chance of chronicity. And I think this is already, and this is also the algorithm how to approach someone with suspected chronic hepatitis B infection. So the markers that you have to look for is hepatitis B surface antigen. If that is negative, and if that person has anti-hepatitis B core positive, which is antibody, then you don't need to worry about that person. Most likely has a previous infection, which has cleared, depending on the risk that that person can be followed. But if that antigen is positive, then depending on the evidence of cirrhosis or chronic liver disease process, you start immediately on antiviral treatment, or you monitor based on hepatitis B surface antigen, envelope antigen, hepatitis B DNA level, and fibrosis assessment. And we always consider risk assessment for hepatocellular carcinoma. And all patients don't need to be treated. There are certain criteria who needs to be treated based on whether they have hepatitis B antigen positive or negative. So everyone with higher level of hepatitis B DNA, hepatitis E antigen positive, serum aminotransfer is very high, more than 2 times upper normal limit, regardless of severity of histologic disease, has to be treated. But some of the other patients can be followed with the above parameters and be considered if they need to be treated. But majority of these cases are handled by ID physicians or hepatologists or GI, depending on how available they are. And as I've said, there are several classes of hepatitis B treatment, but it's not as extensive as hepatitis C. As you know, the older treatment is interferon-based, which is pegylated interferon alpha was the mainstay of treatment. But nowadays, it's not favored. It's used only in milder cases because of a lot of side effects. It has to be given injectable once a week. And in the past, we used to see a lot of side effects from this, including leukopenia, thrombocytopenia, psychiatric issues, including depression. Therefore, this is a less favored treatment, but it has some values in milder cases, and it's contraindicated in people with decompensated cirrhosis because it may flare up further precipitation of decompensation. But I don't think this is a mainstay of treatment as well in Ethiopia, but the duration is 48 to 72 weeks. The mainstay are three group of drugs, nucleoside and nucleotide-based regimen, including lamivudine, entecavir, and tenofovir based, especially we call it TDF and TAF, is a mainstay of treatment now in worldwide, which is potent, and resistant is not clearly being identified in this group of patients. And one thing we have to understand is majority of hepatitis B patients, they get screened for HIV, and if they have one, then you have to target treating both with a common medication. As you know, lamivudine as well as tenofovir medications are effective antiretroviral or anti-HIV medications. The remaining class of medications are rarely used. It's just for informational purpose. And this is also the highlight of what this class of medications, and the entecavir is one thing we have to be very sure that if someone has HIV as well, cannot be used because it doesn't have any anti-HIV activity. But the others, TAF and TDF, are like I said, high potency, high genetic barrier to resistance. This class of medications are the main one. Again, this is a summary of the main medications with potential cure and how long to use. But we will have to stress that hepatitis B treatment with oral medications is a very long process, because you don't want to stop it and anticipate a relapse. But there are some criteria how to stop in a patient who has been on these oral agents. What about those people who are not on treatment? How do you, what do you do with them? You just follow every 3 to 6 months, depending on the risk, whether they are hepatitis E positive or not. You follow them every 3 to 6 months with serology and hepatitis B DNA levels. And this is the area that was, how do you stop whether the hepatitis B patient is treated and effectively controlled? So long-term suppression of hepatitis B DNA and induction of hepatitis E antigen loss, which means if somebody loses hepatitis E antigen, then there is a high chance of cure or controlled rather, and biochemical response like ALT normalization, and loss of hepatitis E antigen, like I said, with development of antibody for hepatitis B surface. The other area which we have to focus is how do you follow people for suspicion of hepatocellular carcinoma. So you have to identify high-risk groups. Of course, in the other setting in here, And elsewhere, we focus on African Americans, Asians, depending on their age, and people who have cirrhosis already. Those people definitely have to be followed for hepatocellular carcinoma, and people with high level of hepatitis B virus DNA. And the risk is higher in male, in older, and family history. People consume alcohol, and persistent elevation of ALT. And how do you follow them? In the past, as you know, there is a marker called alpha-fetoprotein, which has been used, but it has been noted that the sensitivity and specificity is very poor. It's no more used nor recommended. And the current recommendation is these people has to get liver ultrasound every 6 months. How do you prevent? Of course, hepatitis B is preventable. It's universal vaccination for infants and children, for non-immune adults at high risk has to be vaccinated. And infant born to a chronically hepatitis B mother should receive immunoglobulin at birth, and hepatitis B vaccination should be started immediately. And other high-risk groups include healthcare workers exposed, to suspected hepatitis B has to be considered for hepatitis B immunoglobulin as well as hepatitis B vaccine. And mothers with high level of hepatitis B DNA has to be considered for treatment in the 3rd trimester to prevent in utero transmission to the unborn babies. And of course, there are other risk groups that I mentioned already. These are the special population that I mentioned that has to be always screened: HIV patients, hemodialysis patients, pregnant mothers, and healthcare workers. And prevention, like I said, generally, hepatitis B vaccine is the main way. Universal childhood immunization within 24 hours of birth is considered the main way to prevent this infection. These are the references, and I'm sure you would have some questions, but majority of these informations are available at hsvguidelines.org, which is our standard reference for all group of hepatitis C patients. And the other very important reference is University of Washington.edu regarding hepatitis. It has all the information in modules for all hepatitis C. And you can see also CDC and WHO would be a good resource. Thank you very much.
Thank you, Dr. Yoseph, for this wonderful presentation. Really, again, for taking your time and giving us highlights really in detail of hepatitis B and C. I hope the attendants learn a lot from this lecture. I would like to ask them to give them opportunity if they have any question to forward it to you at this point. Anyone who has any question? There is no question in the chat box. Okay, I guess if there is no question, we will stop here. Again, I would like to thank Dr. Yoseph for the presentation, and all of you who attended the lecture for your attendance. I will post the recording of this lecture on Ethiopian Diaspora Physicians Association Action Group Facebook, and I will also send you the PowerPoint presentation through your chiefs. Thank you very much.
Thank you.
Good day, and bye everybody.
All right, bye-bye.
Thank you, bye.